Hello, my name is Mark Hutchinson. I'm the CIO at Gloucestershire Hospitals NHS Trust. We're going to talk about digital leadership during challenging times. The mission, if you like, that I accepted when I came to Gloucestershire Hospitals was to try and take an organisation that was experiencing some real challenges, that had a very poor digital infrastructure and had just recently gone through a failed PAS implementation, and try to help that organisation get from a place of being a digital laggard, hopefully to being a digital leader. We're going to talk about the importance of getting investment and trust from both clinicians as well as from the board. And then we're going to talk about how all of that made it possible for us to go live with a new set of functionality during the COVID-19 pandemic. The first step, as always, is getting the basics right. We had a PAS system that didn't allow national reporting. We had a PAS system that meant we had empty outpatient clinics. We had no proper waiting list data. We were really struggling. And of course, our IT infrastructure, having not really been invested in for a decade, meant that we had 3,000 PCs that were over 6 years old. We had lots of networking equipment that was more than 15 years old. We had about 300 PCs across the organisation that had no antivirus on whatsoever. We had an organisation that had really lost faith in the team that had been here previously. And in the middle of that, my challenge, while fixing the PAS problems that I'd come to fix, was to try and convince the board and the clinical teams to invest their time, their energies, and very scarce money in investing in an electronic patient record. Of course, the board are really important because everything is going to cost money to an extent. So taking the board on the journey that we went on of fixing the PAS implementation, taking them on the journey of fixing some of the infrastructure problems, helping them see the small wins along the way so that they gained confidence and had a reason to continue to invest in our digital maturity was important. And the clinicians who had felt hugely frustrated by the problems that had been experienced here previously needed to believe that we were going to implement a system that was proven and worked, and that we were going to do it in a way that understood the way that they provided care in this organisation. And so we chose Allscripts, Sunrise Clinical Manager, as our EPR, a tried and tested product. We could take clinicians to a global digital exemplar site in Salford and show them with this system being used successfully in a UK hospital. And importantly, this was a system that was flexible. It allowed us to sit down with teams of clinicians across Gloucestershire and design processes and design clinical pathways around the way that they worked and the way that they provided care. And that flexibility meant that we could start with nurses first. That was an area where there was huge support in the organisation. It was an area where there was a great opportunity for us to improve the safety and the reliability of care. And of course, it's a part of the care process where huge amounts of paper are being used. And so when we started the project in July 2019, we had a go live date in mind of June 2020. 12 months later, but in reality, we were able to go live 7 months early in November 2019. e-obs, we had a plan to go live again in June 2020, but we did that much earlier. And order comms was scheduled to be December 2020, but we intend to go live 4 months early in August. So we came to a really interesting and challenging decision point in the middle of March. We had a plan to go live with electronic observations and the News 2 score all being calculated and recorded within the EPR. That was scheduled for the 2nd or 3rd week of March, and it was just as activity was really picking up as a result of the COVID pandemic. We were seeing significant numbers of patients. We were reorganising the way that care was provided. We were moving our clinical teams into unfamiliar surroundings, unfamiliar shifts, different teams, and we had to decide, do we want to implement some really big, significant clinical change when all of these other things are happening, when lots of people were nervous about that. But on the other hand, we understood there were really significant benefits for our patients if we did. And so that third week of March, we went live with electronic observations across both of our sites, across 1,000 beds, all in one go. And it was a huge success. It meant that almost overnight, we were able to identify from anywhere where our sickest patients were. If you were shielding at home, or if you were self-isolating, or if you were just at home for any reason, you were able to access and support clinicians making their decisions. We were able to deploy our staff based on where the sickest patients were, rather than just on generic ward staffing levels. When NHS England decided that they wanted a report of all of the patients across our organisation who were being supported on oxygen, we were able to just press a button in the electronic patient record and produce that report every day, rather than that information being held simply on a bit of paper at the foot of the patient's bed. We were able to provide the acute care response team with information so that they could prioritise their workload, and we were able to quickly identify deteriorating patients in a way that had never been possible when we were just waiting for the bit of paper at the foot of the bed. We have a senior consultant who observed that they were able to identify a deteriorating patient from in their office, and they were able to alert ward staff who could step in and provide the right care at the right time for that patient. The deputy chief nurse is quoted there as saying that she was able to make sure that we had exactly the right staffing levels in the right place to meet the specific patient needs of each of our patients on our wards. And the registrar there, we run 2 hospitals that are 10 miles apart. And despite being 10 miles from the patient in a different hospital, they were able to identify a poorly patient who was clearly deteriorating. They were able to escalate that patient's care. They were able to step in and make sure that that patient got the treatment that they needed as quickly as they needed it. The other things that we got involved in during the COVID-19 period, when it was at its most difficult and most challenging, almost overnight, 2,000 members of our staff needed to be able to work from home and needed to be able to access all of the trust systems from there. And lots of organisations bought hundreds and hundreds of laptops, and we didn't want to do that. We bought 200 laptops, and we provided 2,000 staff with the ability to access all of our clinical systems, all of our administrative systems from their own home PC, their own home laptop, their own home Apple Mac, or whatever device they chose. We ensured that the IT support desk could work remotely and dealt with 5,000 support calls all from within their own homes over those 3 months. We published far more than 100 applications onto that virtual desktop infrastructure so that people at home could access all of those systems from their home device. We've had far more now than 2,000 meetings being held on Microsoft Teams. Feels like I've been on at least half of those. I'm sure it's felt the same for lots of you. We produced a dashboard that could be accessed on mobile phones for all of the execs and the kind of gold tier, so that we could see exactly what was going on with PPE stock levels, with activity levels, with the number of patients on critical care over that period, as well as making sure that we had iPads for virtual visiting when physical visiting wasn't possible. And we set up the 2 private hospitals that we took control of on the EPR. But probably the most exciting thing was making sure that 300 GPs across Gloucestershire could have access to our EPR overnight. They could see all of their patients who'd been discharged within the last 48 hours, and they were able to step in and take over the care of those patients. And what we've been able to see across those practices is really significant reductions in readmission rates for the GPs that have been using our EPR in that period. Of course, the task of engagement, with clinicians as well as with the board has to be an ongoing job. It has to be something that we keep up. It's great to see here probably our most important stakeholder, our chief exec, Deb, who's quoting on Twitter the success that we achieved via the implementation of e-obs and also the success in terms of being able to roll out the virtual desktop infrastructure. Ongoing digital transformation requires ongoing investment. And so making sure that we were able to continue to share our successes, make sure that the board and the clinicians could see the way that we were transforming the safety and reliability of care has been really important. And of course, the COVID period has demonstrated just what's possible when you invest in technology. And it's important we keep up that engagement so that more teams, more clinicians, and the board continue to see value in investing not just money, but also their time in the changes and in the digital transformation that we see ahead of us. So thank you for your time, and thank you for listening.